clock, and your time starts now. Mrs. Peters, an 80-year-old woman, presents to your rural emergency department via ambulance, having fainted in church, now complaining of dizziness and fatigue. She states she's felt odd for a few days now, but had dismissed it as old age. She denies any nausea or vomiting, and states she's been drinking lots of water and tea to help keep hydrated. She reports a history of hypertension, type 2 diabetes mellitus, and coronary artery disease, for which she underwent a coronary artery bypass graft surgery 5 years ago. She takes perinapryl 2.5 milligrams daily, metformin 1 gram twice daily, and aspirin 100 milligrams daily. She was previously on bisoprolol, but it was ceased due to fatigue. On examination, her vital signs show a blood pressure of 110/68 with a heart rate of 36, respiratory rate of 18, and SATs of 97 on room air with temperature of 36.6 degrees and a BSL of 6. Her ECG is shown below. What is your diagnosis? Provide one specific diagnosis. Alright, time is up, and let's go to some answers. Now, this ECG here is one that gets missed, sadly, more often than I would like it to. This is, of course, a third-degree atrioventricular block, or a third-degree heart block, or complete heart block. And answering with that level of detail is going to get you 3 marks. Now, if you were to put sinus bradycardia, that would actually be considered to be a killing answer. So, funnily enough, in this case, it's because it may actually kill the patient if you do miss this kind of thing. And I think this is one of those ones that I think it is easy to miss, because when we think of third-degree heart block, often we think of the really widened QRS complex, and if you have the block high enough, it can actually appear to be fairly narrow still. One of the key things here is that recurrent loss of consciousness with the bradycardia there. We should be paying very close attention to this ECG, and this is where mapping out your P waves and your QRS segments and looking what is the relationship between these two. And if I can get a marker on the screen, the wonders of PowerPoint. Here we can see we have a QRS, 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 and funnily enough, QRS. These are nice and regular QRS intervals, and if we look at our P waves, we've got a P wave, P wave, P wave, P wave, P wave, P wave, P wave. Now, if we were to actually look at the intervals between, say, this section here, looking back, we could say, well, actually, that's probably a P wave there. In fact, that's a P wave there. That might be a P wave there as well. That's a P wave there. You know what? There could be hints of a P wave in that QRS complex. That T wave looks a bit funny. There's probably a P wave there as well. And you start to identify all of these previously assumed missing P waves there. So we have regular atrial activity, regular ventricular activity, but the two ain't talking. They are doing their own little things. That's our complete heart block. All right, hopefully you are satisfied with that answer there. But of course, we have more questions on the way, so let's get 2 minutes on the clock and your time starts now. Question 1.2. What is your immediate management actions? Provide 4 immediate management actions. All right, time is up. Let's get to some answers here. Now, the good thing is, even if you didn't get the last question correct, there's still a very good chance you can get good marks in this question here. Think, what would you do if you had a patient who'd had unconscious collapses or faints brought into the department? So, assuming here that we're dealing with something that's relatively important, this is one of those emergency stations, we should be managing this patient in a resuscitation bay. So specifying where you're going to be managing this patient, remember this is presenting to a rural emergency department, specifying how and where you're going to manage that patient is part of a management plan. For any patient in this situation, you would insert bilateral large bore intravenous cannulas. That's going to get you another mark as well. You would have continuous cardiac monitoring. You would consider transcutaneous pacing if the patient becomes unstable. And in this case in particular, we're referring to cardiology for a pacemaker insertion. Now, it's listed as 1 mark in here. There is a chance you may actually get extra marks for specifying that referral to cardiology if you're specifying for pacemaker insertion. That's going to be, I think, the pivotal thing here that as much as anything else they would want you to do. The reason why they may not have that as extra marks is that could be considered kind of a next step management, and this is specifying that qualifier there of what is your immediate management action. Now, it's still worth marks though, because I think anyone that were to look at that and recognise it straight away, you'd be doing all the things almost simultaneously while getting cardiology on the phone. Let's have a look at here. We've got call ambulance for urgent ED transfer, and yes, as you specified in your next message there, you missed that this was already an ED. And again, this is the place to fall for these traps. Always look at where the setting is, because that's going to have impact on your answer. Insert IV cannula, fantastic. Continuous cardiac monitoring, fantastic. And a referral to cardiology for pacemaker, fantastic. Very well done. All right, of course, we've got more questions here, so let's get 2 minutes on the clock, and your time starts now. Mrs. Peters thanks you for your efforts, but states she doesn't want any further management. Requests that she be allowed to go home to rest and let time tell. You discuss the risks and benefits explicitly, and she states she understands, but still wishes to return home. You assess her capacity to make decisions and decide she's competent. Before she leaves, she hands you her phone asking you to talk to her son, who states he's a lawyer and demands that she be treated. He's listed in her record that he's the medical treatment decision maker with the appropriate paperwork. What actions do you take? Provide 3 specific actions. All right, time's up. And oh boy, anyone that's spent any significant time in ED will have come across a case just like this. And of course, we're not going to be immune in general practice. We're going to have situations like this as well. So always good to know exactly what to do in these circumstances. Now, there will be some variability state to state in terms of the exact approach to this. But the good news is, generally speaking, the approach and the response in this kind of situation will be the same in every single state and territory of Australia. So the things that you should be doing is to advise the son that his mother has been assessed as capable of making her own medical decisions. Now, in the setting of and we'll skip ahead a little bit, in the setting of an a medical treatment decision maker, that only actually comes into power if the patient's deemed as not able to make their own decisions. So instantly, by stating that, this son in particular should understand that he actually can't overrule his mother, that she has been deemed as capable of making her decisions, and we should be respecting that. So the next thing as well is to advise the son that his mother cannot be treated without her consent. The next part is to advise the son that a patient deemed competent supersedes an appointed medical treatment decision maker. You should be discussing this case with your medical indemnity provider, and oh boy, would I be very, very sure to do that as quickly as possible. And of course, make sure that you have carefully documented all discussions. It's the old thing of if it's not written down, it didn't happen, and certainly true in cases like this. You may, depending on where you come from, you may actually be familiar with the care policy. Cover A, I'll let you use your imagination there, retain employment. Care. Take of that what you will. We've got some answers here in the chat from Jenna. So discuss with MDO, fantastic. You did specify medical defence organisation because we're avoiding abbreviations. We should discuss that the medical treatment decision maker is important for when Ms. Peters is unable to make her own choices. Fantastic. Very, very good responses there. Very happy to see.